Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observation and commentaries on the JCO article, The Influences of Comorbidities and Age on Risk of Death Without Recurrence, a retrospective analysis of the ATAC trial by Alistair E. Ring et al. My name is Martin Exterman, and I am a senior member at Moffitt Cancer Center and professor of oncology at the University of South Florida in Tampa, Florida, United States. My oncologic specialty is oncology hematology. The title of the podcast is Comorbidity Data in Cooperative Trial, Feasible and Difficult to Ignore. Breast cancer is mostly a disease of postmenopausal women, with a median age at diagnosis of 61 years and 60% of cancers occurring in women above the age of 50. With the progress made in screening, cancers are detected at increasingly earlier stages, thus decreasing the risk of relapse after resection. The risk is further reduced by the use of adjuvant chemotherapy, radiation therapy, and hormonal therapy. The latter, nowadays, consist mostly of aromatase inhibitors for postmenopausal women with hormone receptor-positive disease. The superiority of AIs to tamoxifen was demonstrated by several randomized trials, the first one of which was the ATAC trial. Furthermore, the risk of relapse of small hormone receptor-positive breast cancers is spread relatively evenly over time, contrary to hormone receptor-negative breast cancers, which tend to relapse mostly in the early years after diagnosis. Therefore, the combination of an older patient population and a low relapse risk spread over several years begs the question: at what point does the risk of relapse and death from the breast cancer become so small that it pales compared to the risk of dying from other causes? One of the early papers to address the issue was published by Statariano and Ragland in the Annals of Internal Medicine in 1994. In their review of a Detroit database of the SEER registry, the authors found that the 3-year survival of breast cancer patients, all stages confounded, was clearly affected by major comorbidities defined as 7 conditions independently affecting survival in their cohort. While the cancer-related deaths were stable across groups, patients with no major comorbidities were 4 times more likely to die from their breast cancer, whereas patients with 3 major comorbidities were 4 times more likely to die from another cause. A weakness of that study is that although stage was stratified, no attempt was made at analyzing the type of adjuvant treatment received or the receptor status of the cancers. In the present study by Ring et al., that is the subject of this podcast, the investigators examined the impact of comorbidity in the ATAC trial, a large, prospective, randomized study of more than 9,000 postmenopausal women with early breast cancer. That trial randomized patients to 3 treatment arms: tamoxifen alone, anastrozole alone, or the combination of the 2, each for a duration of 5 years. The combined arm was closed early for insufficient effect. Therefore, the present study retained only the 2 monotherapy arm for a total of 6,186 patients. The treatment prior to initiation of hormonal therapy was left at the choice of the clinician. 27% of the patients were age 70 and older at study entry. The median follow-up duration is now 10 years. The ATAC study developed forms for recording details on comorbidities. Ring et al. Converted the data on these forms into three well-known indexes: the Satariano Index, mentioned above, the Charlson Comorbidity Index, and the Hypertension Augmented Charlson Comorbidity Index. The Charlson Index is one of the most frequently used indexes in the literature. The Hypertension Augmented Charlson Index is a variant used notably by the Eindhoven Cancer Registry. The deaths following cancer recurrence were considered breast cancer related. Not surprisingly, the authors found that older women were more likely to undergo mastectomy and less likely to receive radiation therapy and chemotherapy. Women above 70 had more risk of recurrence of their breast cancer. This may simply reflect a less aggressive adjuvant treatment. Indeed, a study from the Geneva Cancer Registry demonstrated that even for women in their 80s, proper management of the breast cancer decreases cancer-specific mortality. Bouchardy et al., JCO 2007. It might, however, also be linked to biological differences. An increasing amount of data suggests that the distribution of breast cancers in the elderly might be bimodal, with a subgroup of slow-growing tumors and a second group of small, rapidly growing tumors that have early lymph node metastases. For example, Anderson et al., JCO 2009, Wildiers et al., JCO 2009. A third possible explanation is an interaction from comorbidity. Several studies recently demonstrated, for example, that diabetes increases the risk of relapse of breast cancer, and its prevalence increases with age. So is the case for obesity. Diabetes is part of all three comorbidity indexes studied here. The risk of death without recurrence increased with the comorbidity score, as measured with all three indexes. It is important to note that the impact of each new comorbidity is roughly equivalent to the impact of a decade of age on the 10-year mortality of the patient. A key aspect of this study is that it is large enough to allow stratification of the impact by age. This is important because the prevalence of comorbidity increases with age. The authors demonstrate that comorbidity has a strong impact at any age, although the odds ratio decreases somewhat. Another stratification used by the authors addressed the risk of dying from breast cancer versus other causes stratified by nodal status. Whereas above the age of 70, all women with node-negative disease were more likely to die from another cause than breast cancer, for node-positive disease, only women aged 75 and older with severe comorbidities were more likely to die from another cause. Therefore, it is important to properly treat node-positive breast cancer in older women. For women with node-negative disease, one should note that women above the age of 70 without comorbidity still only had an about 10% risk of dying from other diseases in the following decade. Even the women with a high level of comorbidity were still only 2 to 3 times more likely to die from something else. The sickest older patients had about a 50% 10-year mortality. Therefore, acknowledging that breast cancer may not be the main problem of these patients is by no means a call to inaction. It is rather a call that comorbidity should not be ignored in clinical trial design nor in clinical decision-making. The ATAC investigators illustrate that it is feasible and useful to collect comorbidity data in large oncology multicentric trials. Comorbidity should not only be studied as a competing factor for mortality, but as a potential risk factor for relapse as well. In clinical practice, one should be aware that the benefits on relapse starts diverging markedly from the benefits on survival beyond the age of 75, as we demonstrated in our article in JCO in 2000. Programs such as Adjuvant Online do integrate comorbidity to some degree as well. In summary, comorbidity is a key component of modern clinical trial design and oncology practice and can no longer be ignored when assessing the impact of our therapies on long-term survival. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.